Welcome everyone to this special session entitled KDIGO Symposium on Glomerular Diseases. Over the past 2 years, the KDIGO Glomerular Disease Group has met and worked very hard for the forthcoming updating of glomerular diseases sections. And today we are very pleased to have outstanding speakers on very popular topics from the forthcoming KDIGO updated guidelines on glomerular diseases. And I'm pleased to co-chair this session with Professor Christoph Wanner. And we've just enjoyed his outstanding lecture earlier this morning. And Professor Wanner is the president of VRA-EDTA and also executive officer of KDIGO. And I shall introduce the first speaker, Dr. Heather Reich. Dr. Reich is currently associate professor and hosts the Gabor-Salomon Chair in Nephrology Research at the University of Toronto. And she directs the glomerular nephritis clinical and research program at the University Health Network. And her topic today is KDIGO Guideline on the treatment of membranous nephropathy. Dr. Reich, please.
I would like to thank our Congress and Society presidents, as well as our program committee chairs, for the generous invitation to speak to you today about the KDIGO guidelines on the treatment of membranous nephropathy. Before I start, these are my potential relevant disclosures. I'm not a contributor to the membranous guidelines, although I am part of the IgA nephropathy working group. So I would like to acknowledge the hard work of my colleagues, as well as the KDIGO chairs, Jürgen Flöge, Brad Rovin, and Cello Tonelli. There are several themes that arise in the new 2020 guidelines that I would like to address today. First is the emerging role of the anti-PLA2R antibody in diagnosis of membranous nephropathy, as well as prognosis and therapeutic decisions. And second, since the last draft in 2012, we have new data from clinical trials that outline novel approaches to treatment. I would like to use a case to illustrate the application of the new 2020 guidelines. A 48-year-old male first developed edema and weight gain in 2016. He presented to medical attention with severe right-sided abdominal pain and dyspnea and was diagnosed with a pulmonary embolus, renal vein thrombosis, and severe nephrotic syndrome. He had proteinuria of 19 grams per day and a serum albumin of 10 grams per liter, with serum creatinine of 128 micromoles per liter. Secondary investigations, including serologic and infection testing, were negative. He had a CT chest and colonoscopy, which were negative, and he was managed conservatively with anticoagulation because at the time it was not possible to perform a renal biopsy given the severe presentation of venous thromboembolic disease. And so the question we could not ask at that time is, can we use anti-PLA2R antibody testing in order to avoid kidney biopsy? Can we make a clinical diagnosis in this man of membranous nephropathy without actually performing a biopsy? In terms of diagnosis, the 2020 guidelines offer new approaches. Practice point 3.1 suggests that a kidney biopsy may not be required to confirm the diagnosis of membranous nephropathy in patients with a clinical and serologic presentation compatible with the diagnosis. An additional practice point suggests that patients with membranous nephropathy should be evaluated for associated conditions regardless of whether PLA2R antibody or thrombospondin antibodies are present or absent. So it has been over 10 years since the anti-PLA2R antibodies have been identified in the serum and tissue of 2/3 of patients with idiopathic membranous nephropathy. We're continuing to learn about how to use this tool for diagnosis and treatment. New knowledge is reflected in the updated guidelines. The original assay used to detect anti-PLA2R antibodies was the Western blot performed under non-reducing conditions. However, this is not a commercially available assay. It does remain the gold standard in terms of sensitivity and specificity. it is important to be familiar with the commercially available assays to interpret and apply the new guidelines using anti-PLA2R antibodies for diagnosis. There are two commercially available assays, both produced by Euroimmune. On the left, you can see the cell-based indirect immunofluorescence assay. On the right is the familiar ELISA assay, and both have specific operating characteristics unique to the technology used. The overall sensitivity of the Western blot is the highest, and this is followed by the indirect immunofluorescence cell-based assay. And finally, the lowest sensitivity is the ELISA with a sensitivity around 96%. The specificity is relatively high for all of the assays. In the table at the bottom, you can see data from the package inserts of these assays, which reflect the reference ranges for positivity. And even if we extend the lower limit below 14, the ELISA still has the lowest level of sensitivity. So those are the technical aspects related to assay characteristics, but there are also biologic variables. The dominant antigen is the cis-R residue, and this can have a slightly different geographic distribution, which can affect sensitivity of assays. In addition, the biology of the disease itself really affects sensitivity and specificity estimates. This slide represents the progression over time of clinical and immunologic disease activity. The yellow shape on the bottom represents PLA2R in glomerular deposits, and time is on the x-axis. So if you start at the far left, you will see that actually the presence of glomerular deposits of PLA2R and antibodies likely precedes the detection of anti-PLA2R antibodies in the serum because the kidney simply acts like a sink. Initially, those antibodies are mopped up into the kidneys prior to reaching a threshold, at which point they become detectable in the serum. The injury caused by the presence of these antibodies then leads to proteinuria thereafter. And through the course of the disease and resolution, whether it is spontaneous or following treatment, first the immunologic activity will shut off, and that is denoted by a reduction in the detectable anti-PLA2R antibodies. And the clinical response or proteinuria will tend to lag behind the immunologic remission, and that can be by several months. So of course, sensitivity and specificity of our assays is going to depend on when the assay is taken in the biologic course of the disease. So back to our case. With an absolute contraindication to biopsy, can we use serologic testing to rule in or rule out membranous nephropathy? The suggestion that a serum PLA2R assay can be used to avoid kidney biopsy comes from data from a single observational study. In over 800 patients, there were 97 who had positive PLA2R antibodies detected by both immunofluorescence assay as well as cell-based assay. They had biopsies available for analysis, and they also had negative investigations for potential secondary causes, including autoimmune screen, malignancy workup, medication review, and paraprotein measurement. These patients were largely Caucasian and male. They had positive titers in the range of an average of 60 by ELISA, and of course, by definition, all had positive IFA. Of the patients that had GFRs over 60, which was their initial hypothesis, by and large, they all had membranous nephropathy without evidence of another histologic diagnosis that would have affected treatment. One patient had superimposed FSGS, one had superimposed diabetic nephropathy, and none showed any histopathologic characteristics that were suggestive of a secondary cause of membranous nephropathy. In patients with a GFR under 60, which was 37 patients, there were some additional diagnoses noted on the kidney biopsy. One patient had coexistent AIN, another patient had coexistent crescents, and another patient had ATN, and so these were findings that potentially could have modified treatment decisions. However, based on this study, this illustrates the author's recommendations that in patients that have a high or borderline high ELISA positive assay and have immunofluorescence assay positive, can have a clinical diagnosis made of membranous nephropathy and avoid kidney biopsy if all secondary investigations are negative and renal function is normal. So the take-home messages from this study and from the guideline is that in patients with relatively preserved kidney function, when a biopsy is contraindicated, such as in the case of the patient I described, a positive anti-PLA2R antibody in the serum is a helpful and actionable finding. However, it must be done with secondary screening, and a negative serum test does not rule out membranous nephropathy or anti-PLA2R positive membranous nephropathy. There's likely more work required to define the thresholds for positivity, and we also don't really understand how to apply this when most centers only use one test for anti-PLA2R antibodies. I don't know of too many centers that are using both the cell-based assay as well as the ELISA simultaneously. The new guidelines are clear that detection of a PLA2R antibody does not rule out secondary disease. In the original study by Western blot, there were very few patients that had secondary causes of membranous nephropathy, only 8. And so it was not sufficient to determine the characteristics of antibodies in patients with secondary membranous nephropathy. Only a small number of cases were included. Newer data, however, suggests different. We can see that in anti-PLA2R antibody positive patients, at least 14 out of 80 had detectable secondary causes. Some of the more frequent causes of membranous nephropathy that we see that are associated with anti-PLA2R are sarcoid, hepatitis, and there are, of course, neoplasms, which may be coexistent or may be causative. I want to highlight some newer studies as well that show that hepatitis B patients frequently can have anti-PLA2R positivity, up to 64% in patients with membranous nephropathy. And in SLE, reports are continuing to show that anti-PLA2R autoantibodies are not rare. Up to 5.5% of patients with SLE will have anti-PLA2R antibodies. 5 out of 7 in this study that had membranous nephropathy had tissue anti-PLA2R antibody positivity. So again, as the KDIGO guidelines suggest, these antibody tests are not sufficient to rule out secondary disease. The new KDIGO guidelines clearly illustrate that anti-PLA2R antibody testing does not negate the need for solid screening for secondary causes of membranous nephropathy. And back to our case. 3 months later, the patient presented with extension of the PE, was started on low molecular weight heparin, and the treating physicians gave him prednisone 20 milligrams daily and tacrolimus 2 milligrams BID. Within 2 months, he developed very severe hemarthrosis that required operative intervention. At the time, anticoagulation had to be stopped, and the opportunity was taken to perform a kidney biopsy. The silver stain clearly showed thickened basement membranes, as well as evidence of spikes, an engorged capillary loop with extravasated neutrophils in keeping with the renal vein thrombosis. The IgG and anti-PLA2R immunofluorescence were both positive, and the EM showed ongoing subepithelial deposits of immune complexes. Once the diagnosis of membranous nephropathy is made, the guidelines suggest using clinical and lab criteria for risk stratification. And of course, this is important for decisions about treatment, also informing patients about their risk. And finally, it is helpful in terms of interpreting clinical trials. And you'll see the new guidelines include things such as PLA2R antibody titer, as well as urine molecular weight protein excretion. And I'm not sure that this is going to be the final stratification strategy because not all of these are readily available clinical tests. In patients with moderate or high risk, the first line of therapy is now Rituximab, and very high risk remains cyclophosphamide. This, of course, reflects new data from the MENTOR study, which included 130 patients randomized to treatment with either rituximab or cyclosporin. And in this study, the primary endpoint was complete or partial remission of proteinuria at 24 months. And this patients were shown to have a far higher rate of remission at 24 months in patients who received rituximab compared to patients who received a 12-month course of cyclosporin. Patients included in this study had quite a high anti-PLA2R positive titer, although a different assay was used. Serum albumin was low, urinary protein was 9 grams per day, so really this was actually quite a high risk population at the time of randomization. And if you look at the number of patients in complete or partial remission at 1 year, it was 60% in patients treated with membranous, 52% with cyclosporin, which was not statistically significantly different, but this was not the primary endpoint. It was at 24 months, where, of course, more patients were still in remission if they had received rituximab. In terms of time to relapse, it was much shorter in patients who received cyclosporin compared to rituximab. And in terms of adverse events, trends suggested a higher SAE rate, serious adverse events in the cyclosporin group. However, this did not quite reach clinical statistical significance. The adverse events in the cyclosporin group consisted of quite a high number of GI side effects. There was a numeric trend in infection risk that was higher in patients receiving cyclosporin. And in the rituximab group, of note, 25% of the patients had some sort of infusion reaction. Importantly, though, increase in creatinine was noted in 6% of patients having received rituximab compared to 23% of patients who had received cyclosporin. The guidelines recommend that at 3 months, PLA2R be a central decision point in terms of determining response to therapy. And if patients have received any of the therapeutic regimens, at 3 months, anti-PLA2R antibodies should be measured for decisions about additional therapy with rituximab versus addition of rituximab to other regimens. This is based on observations of a relationship between anti-PLA2R antibody titer and remission. In the top left panels, we see two figures from 2 cohorts of patients with membranous nephropathy treated with rituximab, a total of 35 patients. Over time, you can see on the left anti-PLA2R antibody level, on the right proteinuria titer, and over time, anti-PLA2R level falls in parallel and slightly preceding a fall in proteinuria. In the bottom left, we can see in the GEMRITUX study, in red are patients who are treated with Rituximab. Those patients had a rapid and more dramatic decline in anti-PLA2R antibody titer, detectable at month 3, compared to patients treated with conservative therapy alone. And if you look on the far right at that panel, that is a study of 48 patients in a longitudinal cohort study. And here they measured PLA2R with using ELISA at the end of therapy with either cyclophosphamide or MMF. And patients who were anti-PLA2R positive had a much shorter time before relapse compared to patients who had negative titer at the end of treatment. But what can we see from the MENTOR study? Well, there are some supplementary data, and on the left panel we can see the immunologic response of patients who achieved a partial or complete remission over time. And the immunologic response was defined here as normalization of PLA2R antibody titer. And certainly at 6 months, a substantial number of patients who achieved CR or PR were still not achieving an immunologic remission. So I would say that at 3 months, maybe a little bit soon, to expect to see full immunologic response. And if you don't see full immunologic response, it does not necessarily mean the patient is not going to develop a substantial and adequate clinical response. So 3 months, I wonder if that's a bit too soon. On the right panel, you'll see some data illustrating the anti-PLA2R titers according to treatment category in the MENTOR study, and the scale is actually logarithmic. And if you look at month 24, you can see that in the rituximab group, there's still a number of patients with fairly high titers, even though they were in a complete or partial remission at that time. So it's interesting, there are still going to be a few patients that are in a clinical remission but have an antibody titer that's high. Now, these could be patients that are about to relapse. We don't know, but it would suggest that there's still a little bit more that we need to learn about the relationship between PLA2R and clinical disease activity. And 3 months perhaps may be a little bit early to consider that a full immunologic response has not yet occurred. So back to our case, tacrolimus was continued. The prednisone was weaned down to and discontinued after 6 months. The patient was referred to us because of a very slow resolution in proteinuria. The anti-PLA2R antibody actually decreased quite impressively with treatment. And we reassured the patient that the renal vein thrombosis was likely driving the delayed clinical response, and indeed the patient experienced a very slow but gradual reduction in proteinuria and ultimately achieved a good partial remission of 1 gram per day and normalization of anti-PLA2R antibodies. So what does the future hold in terms of new developments in membranous nephropathy? Most of the complications like VTE occur early in the course of membranous nephropathy, and therefore there is an interest in inducing a more rapid clinical response. And this is the hypothesis underlying the study that's underway by the NIH, led by Dr. Waldman, where 6 months of cyclophosphamide are being given in addition to rituximab to see if an earlier reduction in proteinuria can be achieved. And there are some preliminary data that would suggest that this may be the case. Drug repurposing is of interest in membranous nephropathy, and fortunately there are multiple studies now looking at novel agents. As you remember, there was still only a 50 to 60% response rate in these patients with very severe disease, which leaves a lot of room for improvement. This includes studies using the BAFF inhibitor belimumab, a complement factor B inhibitor, a melanocortin agonist, that is the receptor through which ACTH is thought to exert its podocyte effects, and finally anti-CD38 antibodies. So in conclusion, we're all eagerly awaiting the edited and finalized version of the guidelines. There are some important central themes that have really changed, that are going to change the way we practice. And finally, there remains a lot of room for new knowledge, such as in the area of the limits of anti-PLA2R antibody testing. How do we manage the PLA2R antibody negative patients? There's not a lot of attention paid to this, and that's because we need more knowledge in this area. And finally, there remains a lot of room for improving upon our response rates and preventing relapse of this disease. So I thank you again for your attention. This is a picture of Toronto, and I really, this is the hospital where I work, and I would really look forward to having the chance to host guests again once this pandemic is done, and I wish you all good health and safety. Thank you.
Thank you very much, Dr. Reich, for the very clear and very helpful lecture to frontline clinicians. We'll save the questions and answers to the very end, and let us move on to the second speaker, and I pass on to my co-chair.
Thank you, Professor Chan. I would like now to introduce Dr. Vladimir Tessage. Professor Tesar is the head of the Department of Nephrology at the First Faculty of Medicine at the Charles University of Prague in the Czech Republic. Professor Tesar has done his nearly entire scientific life, has studied during this life ANCA-positive vasculitis, lupus nephritis, and the treatment of glomerular nephritis. I think he's the best, the most, has the most knowledge in this field in Europe. He was a long-standing member of the Council of the ERA-EDTA and has lectured multiple times on this topic. He will now go and lecture about KDIGO guidelines in the treatment of ANCA-associated vasculitis. Please, Vladimir, your lecture. Thank you.
Ladies and gentlemen, my today's task is to share with you some information on KDIGO guidelines on the treatment of ANCA-associated vasculitis. Here are my disclosures, and here you see what I am to compare. The already published guidelines from 2012 and the public review draft of the new guidelines, which should appear at the end of this year, 2020. And there is something new in the new guidelines. In the old guidelines, the stronger evidence was associated with recommendation and weaker evidence with suggestion. And you see here that stronger evidence is associated once again with recommendation. Recommendation will be provided when ample evidence is available. And when there is insufficient evidence, what is important to guide in some way, there is a practice point which is used. And here is the list of many randomized controlled trials in ANCA-associated vasculitis. You see that this is a field with much more randomized controlled trials than any other glomerular disease. Here are the studies which were available for the guidelines 2012. And you see that there are many new studies which were published since 2012 until 2020, and which were also used for the modifications of the new guidelines. I will not discuss all of the studies. Those studies in orange are either not so much important or are not referring to patients with renal involvement. But I will shortly mention most of the studies. And we'll concentrate on three major topics: initial therapy and relapse, plasma exchange, and maintenance therapy. So starting with initial therapy and relapse, it's important to remind you that the outcome of ANCA-associated vasculitis at the time, vagus granulomatosis, before introduction of the treatment with corticosteroids and cyclophosphamide was very poor, with median survival of about 5 months and 1 year mortality reaching 82%. And with the introduction of cyclophosphamide, dramatic change occurred. Almost all patients improved. There was many patients who reached complete remission, but there was relatively high 13% mortality. Many patients, half of the patients who went to remission had at least one relapse, and there was a very high risk of bladder cancer, 15-year risk of 16% because of high cumulative dose of cyclophosphamide. And it became apparent that with the introduction of the combination of cyclophosphamide and corticosteroids, the patients are no longer dying so much because of active vasculitis. You see that during the first year, only 19% of patients died of active vasculitis, but much more of them are dying because of infections. And in the second and third years, the deaths because of vasculitis is even decreasing, but there are many patients dying because of infection, cardiovascular disease, and malignancy. So it means that the treatment is effective, but too toxic and should be in some way modified to keep its efficacy but decrease its toxicity. And this was the aim of the UVA studies, which tried to minimize cyclophosphamide exposure, either by early switch from cyclophosphamide to azathioprine in generalized vasculitis. It was not after 1 year as it was done in the 1990s, but after already 3 months. And the second study, Cyclops, by using cyclophosphamide pulses with about 50% lower cumulative dose of cyclophosphamide instead of oral continuous cyclophosphamide. And in the short term, these studies were not associated with an increase of the rate of relapses, but during the long-term follow-up, there was always at least a trend to higher relapse rate in patients with lower cumulative dose of cyclophosphamide, as you see here using the data from Cyclophosphamide, and this was very similar in the Cyclops trial. So there was a higher relapse rate in patients with low cumulative dose of cyclophosphamide, and it was demonstrated as under treatment. It means a low cumulative dose of cyclophosphamide and low dose of prednisolone in the first 3 months was associated with higher relapse rate. So it was clear that minimizing cyclophosphamide is not the best way, and we need something which could replace cyclophosphamide with similar efficacy and lower toxicity. And Rituximab was a good candidate and was tested in the Reich trial in generalized AAV in 2010. And you see here that comparing conventional treatment with cyclophosphamide and corticosteroid followed by AZA with rituximab for remission induction with the main primary endpoint disease activity at 6 months resulted in showing that rituximab is non-inferior to cyclophosphamide when new patients with newly diagnosed ANCA-Associated Vasculitis were assessed, and it's even more effective than cyclophosphamide in inducing remission in relapsing disease. 67% versus 42%, but rate of adverse events was not different in both limbs. There was another small study called Rituximab, which randomized only 44 patients, but with very severe renal involvement, with mean glomerular filtration rate of about 20 ml per minute. And in this study, traditional treatment with cyclophosphamide pulses followed by AZA was compared with rituximab with 2 initial pulses of cyclophosphamide to be sure that the effect of rituximab is quick enough. And once again, you see that even in this very high-risk population, cumulative incidence of remission was quite similar. Sustained remission, the same. Increase of GFR at 12 months was the same. So this was the basis for the recommendation which appeared in 2012 guidelines. Initial treatment of post-immune focal and segmental necrotizing GN. We recommend cyclophosphamide and corticosteroids, and rituximab and corticosteroids were recommended only as an alternative initial treatment in patients without severe disease, taking into consideration that the evidence for these patients is insufficient, or for the patients in whom cyclophosphamide is contraindicated. And the treatment of relapse was suggested in the same way as the treatment of new patient according to the same guidelines. And for resistant disease, it was clear that there is no clear recommendation, and it was suggested that you can use for either IV immunoglobulin, rituximab, or plasma exchange. Since 2012, new data on rituximab were obtained. Sub-analysis of renal patients from Reich once again confirmed that even in patients with more severe disease, rituximab is effective, and there is a similar increase of eGFR during the follow-up. And the data from Rituximab showed that there was no difference in terms of relapse-free and ESRD-free survival between the patients treated initially by rituximab and cyclophosphamide. And what was even more important were the data, long-term data from Reich study, which confirmed the well-known fact that the strongest determinant of relapse risk was the presence of anti-PRC positivity. But in this subgroup of PRC positive patients with relapsing disease, rituximab was better than cyclophosphamide, not only after 6 months, you see the hazard ratio, but also after 12 months and 18 months. And another study which showed that rituximab is really a very, very good induction treatment was Tesar study, which was partly recently published, and in this patient, 190 patients with a relapse of GPA or MPA received all rituximab as remission induction treatment with either higher or lower dose of corticosteroids, and then were randomized to rituximab or azathioprine for maintenance. I will speak about it later. And you see here that the response to rituximab was very good. 90% is a green field of patients achieved remission by 4 months, and there was much more patients who became ANCA negative within these 4 months. And the treatment was well tolerated with a relatively low rate of infectious complications. And the conclusion was that rituximab is highly efficacious for the induction of remission in patients with AAV and relapse. And we know that one of the major problems with cyclophosphamide used repeatedly with high cumulative dose is the high risk of late occurring malignancies, not only of the bladder, but also of in other sites, including skin and including leukemia. And it seems that rituximab is clearly devoid of this risk because in this one-center analysis of more than 300 patients, cyclophosphamide was associated with 3 times higher risk of malignancy, and rituximab was not associated with increases of malignancy. But on the other hand, still the risk of infections in the early phase of treatment seems to be not different in patients treated with cyclophosphamide and rituximab, and it seems to be related to high dose of corticosteroids used in this older regimens. And in Pexiva study recently, the 2 corticosteroid regimens with the traditional high dose and with reduced dose with much quicker tapering of corticosteroids were compared, and fortunately enough, it was shown quite persuasively that lower doses of corticosteroids in this induction phase are associated with similar efficacy, but significantly lower risk of serious adverse events. So this shows that we should really limit the cumulative dose of corticosteroids, and currently it seems that there is even a chance to completely avoid the use of corticosteroids, using instead of them the inhibitor of C5 receptor avacopan. We have data from phase 2 trial in which avacopan was better than high-dose corticosteroids in terms of decreasing activity of the disease faster, decreasing albuminuria, and in terms of rapid improvement of quality of life of patients treated with avacopan. And these data from phase 2 trial were recently confirmed in much larger phase 3 trial in more than 300 patients. You see that at week 26, the rate of remission was similar, and at week 52, it was even better on sustained remission, was even better on avacopan compared to patients and corticosteroids, and even the patients treated with avacopan had better increase of eGFR compared to patients on high-dose corticosteroids, and it means that avacopan is successful as steroid-sparing drug during the induction phase of AAV. Unfortunately, avacopan is not a part of the guidelines, but what is currently in the 2020 guidelines, the first point is that it is important to start a treatment of AAV quite quickly without waiting for kidney biopsy to be performed or reported, and comparing the new recommendation with the old one from 2012, you see that now we recommend the corticosteroid in combination with cyclophosphamide and rituximab can be used as initial treatment of new onset AAV. So rituximab is not only an alternative for those patients who do not tolerate cyclophosphamide, but is on the same level, and you can choose rituximab as an initial treatment of new onset AAV. But still, there is an important warning that in patients presented with markedly reduced or rapid decline in GFR, as defined here, there are limited data to support rituximab, and cyclophosphamide and glucocorticoid should be preferred. But a combination of rituximab and cyclophosphamide can also be considered based on the data from Rituximab trial. There is also a recommendation or guidance when prefer intravenous and when prefer all cyclophosphamide. Generally, intravenous cyclophosphamide should be preferred in most patients, and oral cyclophosphamide only in those where cost is an important factor and when there is a difficult access to an infusion center. And comparing the decision between rituximab and cyclophosphamide, once again, cyclophosphamide is preferred, especially in patients with severe disease and where there is a limited access to rituximab. On the other hand, rituximab should be preferred in children, adolescents, in premenopausal women to preserve their fertility, in frail older patients, and also in relapsing patients and PRC positive patients. And of course, what is also recommended is this reduced dose regimen of corticosteroid derived from Pexiva study. And this is what the guidelines recommend for oral corticosteroid tapering. And if you remember, the guidelines from 2012, treatment of relapse was recommended to be done in the same way as the initial treatment, but based on the data we have, we now recommend that relapsing patients should be treated preferably with rituximab. And for refractory disease, there is also a change, and currently we recommend that those patients who were initially treated with rituximab should be probably switched to cyclophosphamide and the opposite. And of course, usually it is also necessary to increase the dose of glucocorticoids. So the second part of the lecture, plasma exchange. In 27, MIPEX trial showed that in patients with AAV presented with high serum creatinine, plasma exchange is associated with better preservation of independent renal function at 3 months, 69% versus 49%. But there were then different meta-analyses showing that there is no impact of plasma exchange on mortality, but there is an impact on the rate of ESRD, at least temporarily. And this was the reason why the recommendations from 2012 were that we recommend the addition of plasmapheresis in patients requiring dialysis or in patients with rapidly increasing serum creatinine. Then plasma exchange was recommended for patients with pulmonary hemorrhage and also for the patients with a concomitant positivity of anti-GBM antibodies. But since 2012, we obtained the data from long-term follow-up of MIPEX, and after median almost of 4 years, there was no difference in proportion of patients with ESRD or death. And even the difference in the reduction, or even the difference in the reduction of the risk of ESRD did not reach statistical significance. So it seems that the effect of plasma exchange is at best only temporary. But of course, even the delay of the start of treatment for ESRD is important for the patients. And it is also important to say that in MIPEX, the patients were treated with oral continuous cyclophosphamide and that had very high mortality, 1-year mortality of 25%. And this high mortality can be decreased with using IV cyclophosphamide instead of oral continuous cyclophosphamide. But there were many uncertainties, and we believe that we will get the final answer from the by far the largest study ever done in ANCA-Associated Vasculitis called PEXIVAS, which recruited 700 patients with serum creatinine more than 200 micromoles per liter, and they were randomized to the induction treatment with either plasma exchange as add-on treatment or no plasma exchange with a follow-up of 2 years. And you see that it was really a typical population of these patients. There was a 20% proportion of patients who had to be dialyzed at presentation, and 27% of patients had alveolar hemorrhage, and this was severe in almost 9% of patients requiring ventilation or with low oxygen saturation. And these patients had mostly involvement of kidney, almost 100%, and lungs, and were treated mostly with cyclophosphamide, but there was still a proportion of patients treated with rituximab. But rather disappointingly, plasma exchange had no significant effect on primary endpoint, this mortality combined with the end-stage renal disease. And there was no difference in any of the studied subgroups based on age, renal function, or the presence of alveolar hemorrhage. So before the more detailed analysis of PEXIVAS trial are available, between the meta-analysis of all the data is available in the new guidelines from 2010-20, we recommend that plasma exchange can be only considered in patients who are requiring dialysis or with rapidly increasing serum creatinine. So it's weaker than in 2012, and similarly, it should be considered for diffuse alveolar hemorrhage, especially when there is severe hypoxemia. But it should be added to treatment in patients with an overlap syndrome of ANCA-associated vasculitis and anti-GBM. Finally, some words about maintenance therapy. Concerning the maintenance, it was stated in 2012 that most patients need some maintenance for at least maintenance treatment for at least 18 months. And what was at that time recommended for the maintenance was either azathioprine or mycophenolate or methotrexate for some patients with well-preserved glomerular filtration rate. And since that, there are some new data showing that how important is the length of treatment. In the remaining study, there was compared the treatment with continuation of azathioprine until 4 years with early withdrawal at 24 months. And it was shown that the patients who had an early withdrawal were at much higher risk of relapses. And there was also a difference in the risk of end-stage renal disease, suggesting that at least some patients should be treated with longer maintenance treatment than only 18 to 24 months. And of course, these patients at risk were those patients who were ANCA positive at randomization. And what is also important is longer maintenance treatment was not associated with a significant increase in adverse event rates. So once again, especially patients who remain ANCA positive, patients with anti-PRC antibodies should be treated with longer maintenance treatment. We also have some new data on rituximab as a drug used in the maintenance treatment coming from Main-Sun study, which randomized more than 100 patients with relatively mild ANCA-associated vasculitis to either azathioprine or rituximab maintenance, you see that renal involvement was present in 70% of patients, but GFR, mean GFR was relatively high, around 62 ml per minute. And in this study, it was clearly shown that rituximab is better than azathioprine in terms of avoiding major relapses or any relapses. There were almost no relapses during the treatment, and there was a much lower rate of relapses even after rituximab withdrawal. And importantly, there was also no difference in severe adverse events. And the longer follow-up of these patients from Mainridge Sun showed that after 5 years, after 60 months, there still remained the superiority of rituximab in prevention of major relapses, and even major and minor relapses. And there was even a better overall survival in patients treated with rituximab as maintenance compared to those who were treated with azathioprine, with no difference in serious adverse events. And I already mentioned Tesar study, and I will now share with you the yet unpublished data from the maintenance phase of the study, where a patient who reached remission with induction with rituximab randomized either to rituximab or azathioprine, and you can see that rituximab was superior to azathioprine in preventing relapses. This was quite similar to Mainridge Sun study. And of course, what still remains uncertain is what is the risk of relapses after we finish the maintenance treatment with rituximab. But it seems that the risk of relapses after rituximab maintenance is much lower than after rituximab induction only. And now there is an ongoing study called Mainridge Sun 3, which compares shorter and longer 18 months versus 14 months or 46 months of rituximab maintenance. So we will have more data on the optimal length of the treatment. And what are the recommendations? In 2020, we recommend maintenance therapy with either rituximab or azathioprine. So rituximab is new, and low-dose corticosteroids after induction of remission. And it's also stated that following cyclophosphamide, either azathioprine or plus rituximab can be used, but in most patients with rituximab induction, maintenance should be also done with rituximab. And it's stated that the optimal length of treatment is currently not known, but should take, in most patients, at least 18 months. And once again, there is a consideration what should be preferred if a rituximab or azathioprine, and you see that rituximab should be preferred in patients with relapsing disease, PR3, ANCA-positive disease, frail older adults, and in some other groups, such as when we want to achieve glucocorticoid sparing. And here you see the algorithm, which is very different from what was recommended in 2012. Upgrading rituximab, which is now on the same level of cyclophosphamide, so can be used also in the first line of treatment of new patients with ANCA-associated vasculitis. And what is also new is that rituximab can be used as a maintenance treatment. So let me come to the conclusion. Rituximab became the treatment of choice in patients with major relapses and may be used also in new patients with AAV. More data on advanced kidney disease are needed. Rituximab is probably the best maintenance treatment, and the role of plasma exchange needs to be further elucidated. And we have some new exciting data on avacopan, C5a receptor inhibitors, which should be a reasonable alternative to high-dose corticosteroids with at least similar efficacy and lower toxicity. Thank you very much for your attention.
Thank you, Professor Tesar, for your overarching lecture. Very informative. We keep question to the end, and I hand over now to Professor Chan to introduce the next speaker, please.
Thank you, Christoph. I'm very pleased to introduce my beloved teammate, Professor Sidney Tang. He's currently chair professor and U professor of nephrology in the division. And he is also the president-elect of the Asian Pacific Society of Nephrology. And currently, he also holds the position of executive committee member of KDIGO. And he is the editor-in-chief of Nephrology, the official journal of APSN, and also on the editorial board and theme editor of the leading nephrology journals. And today, Sydney is going to talk about new KDIGO guidelines on the management of IgA nephropathy. Sydney.
I wish to thank the Scientific Program Committee and KDIGO for the opportunity for me to present the updated guideline of IgA nephropathy. These are my disclosures. Now, as you know, the previous version of the IgA nephropathy guideline was published in 2012, which was some time ago, and therefore in 2017, KDIGO envisioned the need to update the guideline. And in fact, it started with a controversies conference held in Singapore, followed by 2 workgroup meetings during the ERA-EDTA, where the workgroup discussed how to update this guideline, followed by many more correspondences to improve the update. And some of you would have received this email in June 2020, calling for public review of the first draft of the updated guideline. So in the following 20 minutes or so, I'm going to present some of the features of this updated guideline, including diagnosis, prognosis, and treatment of IgA nephropathy. I believe I would not have time to go into special situations, but perhaps if you're interested, you can refer back to the draft or the final version of the updated guideline later on. So first of all, on diagnosis 2.1, it is a practice point on the considerations for the diagnosis of IgA nephropathy. IgAN can only be diagnosed with a kidney biopsy, and once diagnosed, we need to determine the MESC score using the revised Oxford classification. Note that there are no validated diagnostic serum or urine markers for IgA nephropathy, and indeed we need to assess all patients diagnosed with primary IgAN for secondary causes. And this table here shows some of the important secondary causes, including IgA vasculitis, viral infection, inflammatory bowel disease, and liver disease, and so on. Now, once these secondary causes are excluded, the diagnosis of idiopathic or primary IgA nephropathy can be made. And as I said, we need to then score the kidney biopsy using the MESC classification so that we can risk stratify the patient, not only based on histology, but based on other clinical parameters to assess the risk of progression to end-stage kidney failure in a certain patient. So of course, the next practice point on the guideline will be on prognosis. And practice point 2.2.1 will be the considerations for prognostication of primary IgAN using clinical and histologic data at the time of biopsy to assess the patient's risk of progression using the International IgAN Prediction Tool. Note that this tool cannot be used to determine the likely impact of any particular treatment or to determine which therapeutic regimen to use. And there are no validated prognostic serum or urine markers currently available for IgAN. So I would just want to talk a little bit about this international IgAN risk prediction tool, basically coming from this paper from Sean Barber, in which he assessed over 3,000 subjects from the Velika cohort, Nanjing cohort, and Tokyo cohort. And therefore, in this particular tool, you would have data from Caucasian, Chinese, as well as Japanese subjects. And this is a very powerful tool because here you can see that the prediction model and also the derivation and the validation cohort, they agree to a large extent, showing that they have a high predictive power for progression of kidney disease. This is the actual tool on the web, and you can access this web using this link here. And if you cannot remember this link, don't worry. You can just type QXMD IgAN in any search engine, and this tool would pop up, and you need to enter all these parameters to arrive at a certain prediction probability. So let me just show you an example here. For example, we have a 21-year-old patient presenting for the first time with 1 gram of proteinuria, and therefore a biopsy was performed showing IgA nephropathy, and the patient's GFR is 90, blood pressure is well controlled, 120/70. And because I'm Chinese, so I just picked Chinese here, and the patient was a new patient, so the patient was not on a RAS blocker, and the histology showed M1, mesangial proliferation, but there was no E, S, or T score on the biopsy, and the patient was also not receiving immunosuppression. So what would be the risk of progression of kidney failure in 5 years' time? So this tool will tell you is 11.4% roughly. Now, if you then change the parameters, okay, so if the patient comes to see you, the same patient, the patient is already taking a RAS blocker, okay, and otherwise had the same histologic findings and the same clinical demographic data, what will be the risk? Do you think the risk will be increased or decreased from 11 point something percent? So the answer is an increase to 14%. And I think this is sensible because for a patient who is already receiving RAS blocker and have this degree of proteinuria, the risk of progression in 5 years' time will actually be higher than a patient who is otherwise not receiving a RAS blocker. Now, what if I change some parameters? For example, changing or adding the E and S lesion, okay? And you can see that by adding E and S lesion, the risk at 5 years is actually not much increased, okay? Suggesting that these lesions, according to this tool, derived from those 3,000 patients in the cohort, were not associated with risk of progression. Now, what if I increase the T-score from 0 to T1 and then to T2? You would immediately see a marked increase, okay? Almost a double and then a triple tripling of the risk of progression in 5 years' time. So you can see that the T lesions are actually rather predictive of prognosis. Now, what about ethnicity? I've told you earlier on that I've chosen Chinese here. What if the same patient comes to see you with these lesions, but the patient is Caucasian or Japanese? Okay, so if the patient is Japanese, the risk is actually lower than in Chinese, okay, from 38 to 28%. And if the patient is Caucasian, the risk is further lowered to 20%. So much on the prognosis. Let's come to the third point, which is treatment, okay? The first point is a practice point, is a consideration for treatment of IgA nephropathy. So the primary focus would be on optimizing supportive care, assessing cardiovascular risk, and commencing appropriate interventions as necessary, along with lifestyle modification, including dietary sodium restrictions, smoking cessation, weight control, etc. Now, the reason for coming up with this optimized control was, of course, data from the Stop IgAN trial, in which we see that about a third of the patients who were initially eligible for recruitment became ineligible as a result of optimized supportive control. So the Stop trial also had a long-term observation phase, as shown here, also showing the importance of supportive treatment in patients with IgA nephropathy. In whom you see that over prolonged follow-up, there was actually no difference, no separation in these curves between supportive care and supportive care plus immunosuppression. Now, the next recommendation is now in the pink box, which means that it's not a practice point, it is a recommendation, 2.3.2, in which the guideline recommends that all patients with proteinuria more than 0.5 gram per 24 hours, irrespective of blood pressure, should be treated with either an ACE inhibitor or ARB, but not both. Now, this recommendation was based on an extensive body of evidence showing that hypertension and proteinuria are major risk factors for CKD progression. The quality of evidence for the IgAN population is moderate because of reliance on the indirect evidence from the general CKD study. However, in the judgment of the work group, a strong recommendation, one, you can see that is 1B here, the strong recommendation is warranted because of the consistency of the benefits of treatment of hypertension and proteinuria observed across the spectrum of kidney diseases. And also because of the generally low risk of harm for hypertension and antiproteinuric therapy, and the lack of rationale for a different recommendation for IgA nephropathy specifically. Now, I also told you that there is no need or that we should actually not treat the patient with ACI and ARB. And specifically for IgA nephropathy is also coming from this post-hoc analysis of the STOP trial, in which you can see that around 80%, around 80 patients receiving single RAS blocker and 30 patients dual RAS blocker. And you would see that over follow-up of up to 3 years, there was actually no difference between the two groups in terms of proteinuria and also eGFR. Okay, the next treatment recommendation, also in the pink box here, it's recommendation 2.3.3, which is a suggestion that patients who remain at high risk of progressive CKD, despite maximal supportive care, be considered for a 6-month course of corticosteroid therapy. Now, high risk here is defined as proteinuria more than 1 gram a day, despite at least 3 months of optimized care. And once again, I need to stress that there is insufficient evidence to support the use of the MESI score in determining whether immunosuppression should be considered. Now, the reason for using corticosteroid, of course, is mainly coming from this study, which is the testing study, the largest available RCT using corticosteroid in IgA nephropathy patients, in which patients had an average level of proteinuria at around 2.4 grams despite optimized supportive care, and that this level is notably higher than patients in the STOP trial, where patients had around 1.6 to 1.8 gram of proteinuria per day. An early analysis of the testing trial suggested efficacy for corticosteroid, and you can see that the hazard ratio was down to 0.37 for patients who received corticosteroid in terms of patients not reaching the primary endpoint. So therefore, data from this study suggested efficacy in using corticosteroid. Now, of course, there are some caveats on using corticosteroid that we have to pay attention to, and it is important, of course, to stress to the patient about emergent toxicity that may be coming out as a result of using corticosteroid, particularly in patients with low GFR. And on your right-hand side will be the practice points showing some of the extreme conditions where we need to apply caution before prescribing corticosteroid. And this include patients who have low eGFR, diabetic patients, obesity, patients with latent infection, secondary disease, peptic ulcers, and also uncontrolled psychiatric illness. And therefore, you would see that this particular recommendation 2.3.3 is a 2B recommendation. This is a weak recommendation due to the significant risk of toxicity with corticosteroid therapy. And consideration of steroid therapy, therefore, must include a discussion with the patient with regard to the potential risk. And the toxicity, of course, toxicity data, of course, was also from this from the testing trial, in which you see a very high hazard ratio for severe or serious adverse events in patients who are on the corticosteroid arm. So whether or not a lower dose of steroid may be beneficial to IgA nephropathy patients with lower serious adverse events, we would have to wait for the testing low dose trial results. Nevertheless, the guideline also provided the steroid regimens used in clinical trials, including those in testing, and also an Italian trial, and also another trial from China. But regardless of any regimen, I think it's worth noting that any patients who are put on a prolonged course of moderate or high-dose corticosteroid should receive prophylaxis against pneumocystis pneumonia, hepatitis B reactivation, along with gastroprotection or even bone protection according to local guidelines. Now let me turn to management of patients with other characteristics. Notably, in this algorithm, you would see specific population, and I highlight here Chinese patients and Japanese patients. So let me talk about Chinese patients first. The practice point 2.3.8 would include information on other pharmacologic therapies, and all these listed here on the top, from antiplatelet agents all the way to CNI, Rituximab, and also fish oil, are not recommended. For Chinese patients, mycophenolate may be considered, particularly in patients in whom corticosteroids are being considered, and mycophenolate may be used as a steroid-sparing agent. Now, why is that so? This is mainly coming from two earlier studies of MMF in IgA nephropathy patients, in which there was notable antiproteinuric effect in patients with IgA nephropathy despite optimized care with full-dose RAS blockade. And a long-term follow-up, so on your left-hand panel is 72 weeks, and on your right-hand panel is a 72 months long-term follow-up, showing again a benefit towards reduction of some of the hard renal endpoints in the MMF group. And more recently, of course, we also have data from this trial from China. This is a single RCT showing that MMF with low-dose corticosteroids was non-inferior to standard-dose corticosteroid for the treatment of incident IgAN patients presenting with proliferative histologic lesions, meaning E or C lesions, with or without necrosis on kidney biopsies and proteinuria more than 1 gram. And note that there were significantly less steroid-related side effects in the combination, which means the low-dose steroid plus MMF arm versus the standard dose steroid arm. Okay, now the next point is actually a practice point with pharmacologic therapy still. And the therapy I wanted to talk about is hydroxychloroquine. Now, why is hydroxychloroquine considered? I think if you look at the pathogenesis of IgA nephropathy shown here, you would see hydroxychloroquine here in the middle panel, and theoretically hydroxychloroquine may be able to reduce stimulation of IgA1 secretion by displaced mucosal antibody secreting cells through interfering recognition of mucosal derived pathogen associated molecular patterns, which have then entered the systemic compartment or circulation from the original site of mucosal infection. Now, how useful is it? Okay, so here you would see a small short-term RCT conducted in China, and you can see that hydroxychloroquine introduced to patients with proteinuria more than 0.75 to 3.5 grams a day, despite optimized RAS blockade treatment, reduced proteinuria by some 48% versus only 10% in the placebo group at 6 months. And of course, this is a short-term study with low patient number, and therefore we would need to see more data on hydroxychloroquine. So in the guideline, you would see a paragraph on hydroxychloroquine on this study, and the recommendation was basically made in Chinese patients and not in non-Chinese patients. Okay, now the next treatment recommendation is actually also a practice point on a special population, the Japanese population. This is a practice point 2.3.8 regarding tonsillectomy in IgA nephropathy. And we know that there are multiple studies in Japan showing improved kidney outcomes, okay, in patients who have received tonsillectomy. However, a single RCT published some years ago failed to show a difference in eGFR at 1 year, comparing the tonsillectomy versus the non-tonsillectomy group. But there was no long-term data available from that particular study. And more recently, using a one-to-one propensity score matching between patients who had tonsillectomy versus patients who did not have a tonsillectomy, the study found that tonsillectomy was associated with a lower risk of renal endpoints, reaching renal endpoints, particularly in terms of improved renal survival in the tonsillectomy group in patients with IgA nephropathy. So therefore, the guideline included a special consideration of tonsillectomy for the Japanese population. Now, the final part of the guideline on IgA nephropathy would include some research recommendations. And the first one, in order to better understand the value of MMF and hydroxychloroquine in different ethnicity, further studies would have to be conducted. Another important research recommendation would be, as you can see here, on the utility of targeted release formulation of budesonide. Now, this targeted formulation, or the Nefficon, is an oral formulation, okay, of budesonide released specifically in the lower ileum, in the ascending colon of the GI tract, particularly targeting the Peyer's patches, because these are areas that are believed to be vested with lymphoid tissue and therefore highly immunoactive. And indeed, an RCT published in 2017 in Lancet already showed antiproteinuric effect of this targeted release formulation of budesonide. And I believe that a phase 3 trial is currently underway to further explore the utility of this targeted release formulation of corticosteroid for IgA nephropathy. Now, finally, in the research recommendations, there are other potentially or theoretically important pathways that can be targeted to treat IgA nephropathy, and they include endothelin receptor blockade, complement inhibition, such as inhibiting the lectin pathway, MAPS2, inhibiting the alternative pathway, okay, blocking factor B, or the final pathway, C5. And also there are ongoing studies exploring the role of inhibiting B-cell activation and survival by blocking BAFF and APRIL signaling respectively. I would like to close by acknowledging all the people who have contributed to this guideline, the controversies conference members listed here, co-chaired by Jürgen Flögen and Brad Vrovin, the work group members. I put a star against John Barrett because he was actually leading and guiding us in compiling this final version of the guideline, and also on the updating of this guideline after we have received the public comments. Along the way, I would also like to thank Jürgen, Brad, and also Cello for helping to edit the different versions of the guideline. I'd like to also thank the KDIGO co-chairs listed here and also the KDIGO staff listed here. Thank you very much.
Thank you very much, Sydney, for the very comprehensive lecture on IgA nephropathy. Now we've come to the question and answers section. The first question is on membranous nephropathy. Heather, are you here? Yes? Okay. Right. So the question is, when and how would you consider adding various treatments in the management of membranous nephropathy?
Oh, that's an interesting question that I actually get asked quite often about whether to add steroid. So there are now some data that show that with addition of steroid, well, I should back up and say that the initial calcineurin inhibitor studies and of course the cyclophosphamide studies included use of prednisone up to around 0.1 per kilo for cyclosporin. And of course, you know, the guidelines for cyclophosphamide use in KDIGO rely on the Ponticelli regimen, when in fact very few people use the Ponticelli regimen exactly as previously described with the alternating months. So this is an important question. We now have data that show that with calcineurin inhibitors, corticosteroids can likely be left out. There was a study looking at tacrolimus monotherapy. The time to remission may be just a little bit longer without prednisone, but it seems to be a reasonable alternative. I think that it is challenging that it's hard to assess the Ponticelli regimen when it's not used as described. And if there is a paper by Dr. Wetzels that described a protocol that was a modified version. So if you're going to be strictly evidence-based, one should use those as models. Personally, I do not use prednisone with calcineurin inhibitors, and it's not in the guidelines. And for rituximab, the only corticosteroids used are at the time to prevent infusion reactions. And of course, this is different than lupus-associated membranous nephropathy, where there probably is a role for corticosteroids.
Okay, and here is a second question. What do you do when the patient seems to be clinically well, but the anti-PLA2R antibody Theta has gone up again after initial response?
So both the guidelines and my personal practice would be to watch until there's a clinical evidence. The only thing that changes my practice in this circumstance is maybe a little closer observation, as well as so more frequent blood work, anticipating that there may be a relapse coming. And right now, I'm not sure about funding in Hong Kong, but certainly in Canada, we would not be able to get funding for medications in the absence of a clinical relapse. So right now, we don't know yet, but I would certainly monitor the patients a little bit more closely.
And just to follow on this question, indeed, if the patient develops a relapse, do you just administer another dose of rituximab, or do you need to check whether the previous B-cell depletion is still effective or not?
So there's a nice chart in the new guideline that suggests that different agents to use in the context of relapse. And if a patient did develop a remission with rituximab, but has a clinical relapse, that repeat dosing with rituximab certainly is very reasonable. I do tend to check for CD20 depletion, just to document that there's the patient, for example, maybe isn't forming antibodies and no longer responding to the rituximab, which is exceedingly rare. But I really base the decisions clinically. And if the patient is relapsing and has had a good response in the past, even if the CD19/20 is partially reconstituted, I think it's reasonable to still give the rituximab again. And certainly from vasculitis literature and from the observational studies in membranous nephropathy, the correlation between CD19/20 depletion and immune and clinical response is not perfect.
Right. Okay. Thank you. Thank you, Heather. So we'll move on to ANCA vasculitis, Tessa. There is a question here. What parameters should be used to guide maintenance withdrawal?
It was already mentioned in my presentation that we should always look at ANCA positivity at the end of the maintenance treatment or at 18 months, and we should be very cautious to withdraw treatment when ANCA is still positive. And the second point is that there is a huge difference between the risk of relapses between anti-PRC and anti-MPO patients. There are still suggestions that anti-MPO patients, at least in some of them, the maintenance should be shorter than 18 months. But in anti-PRC patients, we should be much more cautious. And especially if they are even slightly positive, I would prolong the maintenance to at least 24 months. Or if the therapy is withdrawn, the patient should be under very strict close-up.
Right, thank you. And here is another question. What is the role of pulse steroid in the management of ANCA vasculitis?
The role of corticosteroid pulses is a bit uncertain. There is no strong evidence for that. It's generally believed that it has a strong anti-inflammatory effect. So it should be probably used in patients with very severe presentation, with very active biopsy, with very quick rise of serum creatinine, or with high serum creatinine at presentation. But in my opinion, we can avoid methylprednisolone pulses in patients with milder presentation. And as I said, the benefit of corticosteroid pulses is not well documented and well proven. Thank
you very much, Tessa. And the following two questions are on IgA nephropathy. So, Sydney, what would you do if a patient previously responded with suppression of proteinuria and now the proteinuria has come up again? What is your management plan?
Yes, thank you. I think that's a very common situation. I think the most important starting point is to see if the patient is compliant with the therapy with RAS blocker and other measures. And the second point is to look for any precipitating factors. For example, if the patient had a relapse of proteinuria as a result of recent intercurrent illness, a mucosal infection, a flu, etc. And if that's the case, there may not be a point to restart the patient on high-dose steroid or standard dose steroid. But if you have excluded all these, I think depending on the situation, a repeat course of steroid can be considered, I would have thought.
Would you consider rebiopsy first before a repeat course of steroid?
I think this is also a reasonable approach depending on the interval between the previous remission and the relapse. Okay. Particularly if there are features that suggest that it may not be due to IgA nephropathy relapse, or it could be due to other forms of GN or other conditions.
Thank you. And here is another question. Does the presentation age of the patient matter? If you have a middle-aged person versus an adolescent, would the age of the patient alter your management plan?
So I think in IgA nephropathy, most of the patients are relatively young, and I think the treatment, the guideline does not have any recommendation on the age of the patient with regard to the form of treatment. But I think in general, if the patient is at risk of progression, in the guideline, it says it's more than a gram a day of proteinuria, and one can also use the prediction tool. There is also a recent simulation model published, I think, from Heather's group, from Sean Barber, using some of the parameters from the simulation parameters using the prediction tool to guide the use of immunosuppressive treatment. Because I reckon that in the simulation model, the inclusion of steroid treatment may actually cast some negative effects, as a group of patients in the simulated cohort actually with proteinuria more than a gram a day, they actually did not progress. So I think under the circumstances, the use of the prediction model would be useful. I just wonder if Heather would have any thoughts on this.
I think it's an important factor that needs to be clarified in terms of how we apply the decision tool. Personally, I always remind myself that it is a simulation, and I think we have a fair bit to learn. It would be nice to see the histology from the clinical trials to get a better direction on this.
Right. I think we've come to the end of this session. Thank you very much, all three speakers, for your excellent talk. And I also thank my co-chair, Dr. Wanner. And
thank you.
I would like to thank the audience as well. Thank you very much.
Thank you so much.
Thank you very much.
Thank you all.